Okay, that's very fine. Hi, everybody. Very good evening from my side. And today, I have to talk on osteoporosis. This is the first time I'm going to talk, and a bit scared too, because this is the first time. So I may sometimes talk in Bengali and at other times in English. Please forgive me for that. তো ওই যে এক রোগীর অপারেশন হবে, তো সার্জন আগের দিন রাতে দেখতে গেছে, যে বলছে যে কেমন আছেন, তো বলে যে স্যার খুব ভয় করতেছে। তো বলে কেন? তো বলে যে না স্যার, আমার তো কোনো অপারেশন হয়নি আগে কোনোদিন, তো ভয় করতেছে। তো সার্জন উত্তর দিচ্ছে যে আপনার ভয় করার কোনো কারণ নেই, তার কারণ আমিও আগে কোনোদিন অপারেশন করি নাই। আচ্ছা, হোয়াট এভার. First of all, osteoporosis, a silent thief, like hypertension, which manifests as a stroke, or many medical conditions. Osteoporosis manifests itself only when a fracture occurs. So it remains silent, and like thieves, it is silent. What is that? Osteoporosis, the bone becomes porous, jhazrir moto hoye jay, and it's a generalized skeletal disorder where there is decreased bone mass, and we all know mass is equal to bone density. Bone density decreases, as well as there is architectural deterioration. In this slide, you can see two pictures side by side. The left one is normal and the right one is an osteoporotic bone, where the trabeculae are thinner and it is a weak bone. So because of this architectural deterioration, there is compromised bone strength, and the bones are susceptible to get fractured in trivial trauma, which is called a facility fracture or anything. Next. First of all, we must remember that bones are living tissues. That is, it is always being formed, remodeled, resorption, all these things going on. And in bones, there are two types of cells: osteoblast, which forms bone, and osteoclast, which resorbs bone. The balance between two maintains bone mass. Now, this is another picture, and a picture sometimes tells more stories than words. So here you can see osteoclast, the osteoblasts, how the osteoblasts are repairing the remodeled bone and these things. Next, the bone mass.
Is it possible to go to slide share? Full screen, please.
I'm already on slide share, no?
Yes, sir. Full screen jodi kora jay, sir. Otherwise, it's
full
fine.
Screen. Oh, আচ্ছা, ছোট দেখা যাচ্ছে, right?
মানে ওই যে আপনি দেখবেন যে একটা গবলেটের মতন এই নিচে, মানে পাওয়ার পয়েন্টের নিচের দিকে পাশাপাশি গবলেটে চাপ দিলে
এখন হয়েছে। ওকে,
না এখনো হয়নি। গবলেটে চাপ
তো আমি তো এটা এখানে
গবলেটে চাপ দিলে কিন্তু আপনার এই যে বাঁদিকে যে এগুলো আছে না, ওই যে স্লাইড দেখানো, মানে কতগুলো স্লাইড দেখা যাচ্ছে, ওইটা দূর হয়ে যাবে, ওইটাও থাকবে না।
না এখন শুধু একটা স্লাইডই দেখাচ্ছে আবার এখানে।
স্যার আমি বুঝতে পেরেছি স্যার, আপনি আপনার ফুল স্ক্রিনটা শেয়ার করেননি, শুধু পাওয়ারপয়েন্টটা শেয়ার করেছেন।
অপশনের দরকার নাই, যেটা আছে চলুক না।
স্যার চলুক, জি স্যার, যেভাবে আছে আমরা সেটাই কন্টিনিউ করি স্যার। ফাইন স্যার।
আচ্ছা, তাহলে এটা হচ্ছে বোন মাস। বয়সের সাথে সাথে বোনের কি চেঞ্জ হয়, বোন মাস কতটা চেঞ্জ হয়? At birth, the bone turnover is very high. That is almost 100% of the bone gets remodeled in the first year of life. And thereby, and thereafter, the bone mass increases till around 30 to 35 years of age, when the maximum amount of bone mass is attained. That is peak bone mass, and thereafter the bone mass gradually deteriorates, which becomes more marked in cases of females at menopause. That is postmenopausal osteoporosis. And this is another picture of normal bone and osteoporotic bone. Why osteoporosis is important? It is the commonest metabolic bone disease. 20 million people in the world wide have been osteoporosis. The risk for osteoporosis increases with age. As bone mineral density declines, and senile osteoporosis is most common in persons aged 70 years or older. The frequency of postmenopausal osteoporosis is highest in women aged 50 to 70. 50% of women and 20% of men will have one or more osteoporotic fractures in lifetime. 50% of women and 21% of men after the age of 50. Half of all postmenopausal women will have an osteoporotic related fracture during their lifetime. And 25% of these women will develop a vertebral deformity, and 15% will experience a hip fracture. What are the common sites of osteoporotic hip fractures, osteoporotic fractures? Wrist. It usually comes first. The reason is that because of fall, people try to support themselves with the wrist. So college fracture, this is the commonest wrist fracture. It takes place around 50 to 59 years of age. Then vertebral fracture, usually in the 6th decade. Hip fracture, 90% of the hip fractures take place after the 50 years of age, and most common is in 8th decade. Fracture epidemiology and prognosis. Osteoporosis is the leading cause of fracture in the elderly. Women aged 50 years have about a 50% lifetime fracture rate as a result of osteoporosis. Osteoporosis is associated with 80% of all fractures in people aged 50 years or older. Approximately 33% of women. These are all statistics, forget about that. Anyway, now what are the risk factors of osteoporosis? There are certain risk factors you cannot change, and there are certain risk factors you can change. These risk factors you cannot change, like gender. That is, women, they get osteoporosis much more commonly than that of men. Heredity you cannot change, age you cannot change, fracture history, this osteoporosis is hereditary. It has genetic influences, that is in families. That is, people having more history of family fracture, more family history of fractures will develop, has a better chance of getting another fracture, and certain medical conditions and medications. Next, there are certain things you can change, like calcium consumption. You can increase calcium consumption by eating calcium rich food, vitamin D intake, that is sun exposure, etc. You quit smoking, alcohol consumption, physical activity, posture, low body weight. This is actually BMI less than 20. These people are more prone to develop osteoporosis, and certain medications, most notably glucocorticoids. Next, diseases that are often treated with glucocorticoids. There are many things here. Some of them are rheumatological and very common, like osteoarthritis, psoriasis, rheumatoid arthritis, SLE, multiple sclerosis, and all these things. Clinical features and workup. You take the history, do a clinical examination, go for laboratory workup, image, and then determine the first fracture risk. What are the imaging? Plain radiography, dual energy X-ray DEXA, quantitative CT, single photon emission CT, quantitative ultrasonography, MRI, bone scanning, bone biopsy, and histologic features. But out of all these, DEXA is the most important, and it determines the bone mineral density. When to do a bone mineral density. Any woman older than 65 years and any man 70 years of age should get a BMD testing by DEXA. Postmenopausal women and men above 50 to 69 younger, postmenopausal women and women in postmenopausal transition based on risk factors profile, postmenopausal women and men. These are the indications of BMD testings. Next, imaging, plain radiography. It is a very insensitive for diagnosing, because by the time in plain X-ray you see osteoporosis, the patient has already lost more than 30 to 40% of bone mineral density. Single photon emission CT. It is very useful to localize the bone lesion. Quantitative ultrasonography or calcaneus, points in favor of it is it involves no radiation, it is inexpensive, but it is less sensitive. MRI and bone scan rarely performed. Now, DEXA. DEXA, this is the gold standard for BMD, best indicator of first fracture risk. The risk of new vertebral fracture increases by a factor of 2 to 2.4 for each standard deviation decrease of BMD measurement. And best way to monitor bone mass and future fracture risk after instituting whatever, but the frequency, how often should DEXA be done to monitor BMD development? That's the question. We'll come to that later on. BMD, DEXA usually does BMD at the lumbar spine, hip, and proximal femur. Densitometric imaging can be performed. With BMD, we can do hip structure analysis, trabecular bone score, and finite element analysis. Now, the reason for saying all these things is that determining just BMD is not enough. Why not enough? Because we are going to the next slide. You see here the T-score. T-score of less than 2.5, WHO says that it is osteoporosis. But 50% of the osteoporotic fractures develop with T-scores higher than this and 50% less than this. So BMD by itself is not the only indicator of fracture risk or development of fracture. And this T-score and Z-score, everybody knows about it. -1 to -2.5 is standard deviation. that is osteopenia, less than minus 2.5, that is osteoporosis. T-score less than minus 2.5 with fragility fracture risk, that is severe osteoporosis. T-score compares bone mass, that is BMD of the individual with the peak bone mass. And Z-score, it compares with healthy age and sex and race matched one. Z-score is usually used in premenopausal women, men less than 50 years and children. Values of -2 standard deviation or lower defined as below the expected range of age, and those above 2 within the expected range. Now, fracture risk calculator. It is important to know how often, how risky you are. And the most commonly used scale is that of FAST. It is recommended by WHO, and there are others like Garvan Medical Institute, 4, etc. FRAX in WHO, they use these 10 points, like what's the age, what's the danger, previous fracture, femoral neck BMD, low bone density. These are the FRAX, and these instruments, they are available online. Anybody can see, and WHO site, on WHO site also it's available. So anybody can, if you know your BMD, you can determine your fracture risk in the next 10 years. This is one of the FRASC. This is another, and this is another, right? Next, a few words about quantitative computed tomography. We said that DEXA is the gold standard, but a quantitative CT, they have merits too. Like, say for example, here if you see the slide, you can see it images trabecular bone better than that of DEXA. So some authorities, they recommend quantitative CT to be used in cases of vertebral osteoporosis imaging, because they give a better trabecular bone scanning. BMD is comparable. It does not involve any dye. It can be done within seconds, but more radiation exposure compared to, say, DEXA, and costs are similar for both. Next, let me see. Quantitative. Also, there are some biochemical markers useful in. These biochemical markers are useful in eliminating, in monitoring response to treatment, and they're better than DEXA in monitoring. There are some in the serum, some in the urine. There are lots, many names, difficult to memorize, and I don't want to remember this thing. Anyway, osteoporosis is very underdiagnosed and undertreated condition. Unfortunately, despite the advances in treatments for osteoporosis over the last 25 years, osteoporosis treatment rates remain low, and osteoporosis remains undiagnosed in postmenopausal women and older men. Next is, let me see, this one, diagnosis of osteoporosis. When do you diagnose osteoporosis? That is T-score of -2.5 or less. This is one, and there are others. NOF, that is, this criteria are set up by National Osteoporosis Foundation of the United States, and these are these T-scores. They are more or less similar. American Association of Clinical Endocrinologists, they set up the criteria for diagnosing osteoporosis. Next is treatment approach. American College of Physicians, they have given these 6 recommendations. Out of that, 2 are strong. That is pharmacological treatment. Women with known osteoporosis should be treated to reduce the risk of hip and vertebral fractures, and you can use bisphosphonate or denosumab. This is one. Next is in postmenopausal women, estrogen or estrogen plus estrogen or raloxifene should not be used for the treatment of osteoporosis. And weak recommendations are pharmacologic treatment should last for 5 years. Last for 5 years. But this and it should be monitored. Whether you should monitor BMD during these 5 years and how often, that's a question. The question is because despite change in BMD, whether it changes BMD or not, the fracture risk definitely get lessened with bisphosphonate treatment. So BMD monitoring may not be indicative of fracture risk. For women, God knows, whatever, in men with clinically recognized osteoporosis, okay, fine. Next, let us go to treatment. Treatment is non-pharmacological as well as pharmacological. Non-pharmacological, like lifestyle modification. Sedentary lifestyle is definitely a deteriorative condition for osteoporosis, because when the bones are subjected to mechanical stresses, the osteoblasts, they get stimulated and they start bone forming. And those people who are active in their younger life, they develop their peak bone mass at a higher level. So before the age of 30, you should exercise for vigorous exercise and build up your peak bone mass, so that even after loss, you maintain a sufficient strength in your bone. And regarding diet, that is adequate calcium and vitamin D, exercises, rehabilitative measures, fall prevention strategy. These are the non-pharmacological agents. And pharmacological, that is drugs, predominantly 2 classes of drugs, one that inhibit bone resorption and one class that stimulate bone formation. Next, okay. Exercise and osteoporosis. What's the difference? How does exercise help in osteoporosis? Immobility or mobility. That is, if a patient remains immobile for some reason, bedridden or whatever, his bone is not subjected to gravity or mechanical stress, he develops osteoporosis. On the contrary, if in an osteoporotic bone, you apply too much of load, the bones are likely to get fractured. So you must load the bone with appropriate weight. That is neither too much nor too less. Strengthening of muscles. Strengthening of muscles definitely increases the stress on the bone and thereby stimulates osteoporosis. And in this regard, weight-bearing exercises are better. And balancing exercises, they help maintaining balance so that there are less falls and less chance of exercise. Next, pharmacological therapy. No treatment can completely reverse progression of osteoporosis. We have lots of drugs, we'll come to that later on, but none can completely reverse osteoporosis. early intervention can prevent its development. So intervene as early as possible. Treatment of established osteoporosis can halt progression and reduce fracture incidence. Avoidance of causes of secondary osteoporosis, that is, for example, glucocorticoid use, that is also important. You must avoid causes of secondary osteoporosis. Now, to treat or not to treat. Here, first assess the clinical risk factor, which may or may not include history of fracture. That is, with history of fracture, without history of fracture. Then calculate fracture risk. You can use FRAX as recommended by WHO or Garvan MI or whatever. There are many tools. And calculate the BMD. If BMD is less than 0.25 standard, treat. And osteopenic women with 10-year fracture risk of greater than 12%, you should also institute pharmacological therapy. Now, what pharmacological therapy we have? One is bisphosphonates, that is alendronate, residronate, zoledronate, ivandronate, etc. Second group is SERM, selective estrogen receptor modulators, raloxifene, benzodiazepine, etc., etc. Next, a newer class of drug, that is monoclonal antibodies like denosumab and romosumab, parathyroid hormones like teriparatide and abaloparatide. Next is bisphosphonates. Alendronate, it comes as 10 milligram or 70 milligram. It can be given daily or weekly. Route is oral. It reduces hip, spine, and non-vertebral fracture by about 50%. Regarding these bisphosphonates, a very common problem is that they are absorbed poorly from the GI tract. That is, around 5% gets absorbed only. Bioavailability of this drug is very poor. Second thing is that it should be given in empty stomach, and many a patient do not tolerate. So in that case, we can go for other routes like we can use zoledronate by intravenous. Anyway, residronate, it can be given 5, 35 or 150 milligram dose. Daily, weekly or monthly dose is available. And it also reduces fracture, vertebral fracture rate by 41%, non-vertebral fracture rate by 39%, etc. Regarding ivandronate, clinical trial has not proved that it can interfere with non-vertebral fractures. I think the most devastating of all these osteoporotic fractures, it is the hip fracture that matters most. And since ivandronate, they don't have any effect on hip fractures, how much it will help and whether should it be used, that's a question. Atik Bhai can say better, whatever. Next, sorry, parathyroid hormone analogs like teriparatide. This is a recombinant human parathyroid hormone, anabolic agent, that is, they stimulate osteoporosis, thereby increases BMD both in spine and also hip by 13%. They should be given in post-measured women at high risk of fracture or of intolerant to bisphosphonate. Problem is that they are not recommended for more than 2 years because in some cases malignancies like osteosarcomas has been documented, and continuous treatment stimulates osteoblasts as well as osteoclasts, so that their bone resorption also occur along with bone formation. So they are usually given intermittently. And regarding abaloparatide, there is a black box warning. Though it reduces vertebral fracture by 86% and non-vertebral fractures compared to placebo. Now, denosumab. These are monoclonal antibodies, right? And they, like denosumab, it binds to rank L ligand, that is receptor activator of nucleotide kappa beta ligand, and thereby inhibit osteoclastic bone resorption. They are given in subcutaneous injection every 6 months in a dose of 60 milligram, significantly increases BMD at all sites, more than the bisphosphonate. But there is little difference in reduction of fracture rate. Another monoclonal antibody, romosozumab, it binds to this bone protein sclerostin and inhibit bone resorption and stimulates bone formation. That is, this romosozumab, it increases bone both by inhibiting osteoclast as stimulating osteoblast, but it has a risk of this cardiovascular risk, that is like myocardial infarction or these things. This is how denosumab acts. It is binding to this rank and inhibiting the osteoclast. So bone formation is accelerated. Take a point here is romosozumab is a potent bone anabolic agent and used in severe osteoporosis or those that fail other therapy. It reduces vertebral fracture more than the non-vertebral fracture. Romosozumab can be followed by denosumab, and that is the best approach. Cardiovascular side effects are seen in clinical trials with romosozumab. Other drugs, there are certain other drugs like salmon calcitonin, hormone replacement therapy, strontium ranelate. These are less commonly used. Take-home message is osteoporosis is a serious health problem which is underdiagnosed and undertreated. Because of more aging population, the incidence of osteoporosis associated fracture will increase dramatically in the coming days. The prognosis for osteoporosis is good if bone loss is detected in the early phases and proper intervention is undertaken. Happily, more and more effective drugs are being developed to combat osteoporosis. Patient education is an invaluable component in overall management of osteoporosis patient. And this is my last slide. That is, thank you all. Thank you for patient hearing. Thank you, BD physician, and thank you, SKF.